Good morning, all. Myself, Razia Nagarwala, professor and HOD from the Sancheti College of Physiotherapy, welcome you all on today's panel discussion at Scientifica 11 2021. As we all know, there is an exponential surge in the COVID-19 cases. It has affected our life in many ways. It has taken us from the classroom teaching to online teaching, a big problem for the teachers also. Today, we are having a virtual conference because of COVID-19. As we were having more patients of COVID, it has given rise to many new physiotherapeutic management techniques, methods like tele-rehabilitation, and several challenges in the form of post-COVID complications. Hence, today we are discussing about the post-COVID post-COVID complications and physiotherapy management in today's panel discussion. We have with us four eminent physiotherapists who are academicians and, of course, very keen researchers. And they are not only expert in their field of cardiovascular and respiratory physiotherapy, but they were all part of the task in acute care management of the COVID and post-COVID patients. They will be sharing their experience and knowledge with us. We look forward to an enlightening discussion. Kindly share your question with us during the session. They will be answered at the end. So, to come to introduce our panelists, we have Dr. Narasimhan Swaminathan. It gives me immense pleasure to welcome you, sir. He is a physiotherapist, educator, and a researcher, working as a professor of physiotherapy and vice principal, Faculty of Allied Health Sciences, Sri Ramchandra Institute of Higher Education and Research, Chennai, India. He completed his post-graduation in cardiopulmonary physiotherapy. He's a former fellow and is currently pursuing his PhD in health profession education. Sir, very nice subject to be taken as a PhD. He was trained in a blended learning and quality assurance in higher education during his tenure as a Dean, Faculty of Health and Life Sciences, INTI International University, Malaysia. Sir is visiting professor at Bournemouth University, UK, and adjunct researcher to University of South Australia, Adelaide. We welcome you, sir. Our next panelist is Dr. Umanjali Damke, who is a principal and a professor, School of Center, Government Medical College, Nagpur. Her contribution in treating COVID is tremendous. She has done her MPTH from Lokmanya Tilak Medical College, Sion Hospital in 1993, received base paper awarded in 1991 and 92 at IIP conference, received the Golden Jubilee Award for the contribution towards the physiotherapy in a national conference at IIP at Delhi on 2012. She was a Senate member of MUHS Nashik. Our next panelist is Dr. Anjali Bise. She is a principal at Government Physiotherapy College and Spine Institute, Ahmedabad. She is a professional academic experience of more than 30 years. Her PhD topic was effect of arm ergometry training on the lipid profile, PFT, cardiopulmonary endurance, and quality of life in individuals with spinal cord injuries. She is passionate about her health promotion. I'm happy to introduce our next panelist, Dr. Maria Jayandani. She is an associate professor at GS Medical College at KEM Hospital, Mumbai. She is a head of the GSMC MUHS UNESCO Biotech Unit, former fellow and faculty, member of Board of Study and faculty at Allied Health Sciences MUHS, convener Mumbai branch IIP. She has been the lead faculty in charge at KEM Hospital COVID Ward and COVID ICU since June 2020, with an experience of treating more than 5,000 patients to road to recovery. Her team is involved in both face-to-face and tele-rehabilitation session. Post-COVID resumption to work is focused upon. It is only after they give them fitness that they are allowed to resume the work. They have been working hand in hand with the medicine and chest medicine department in management of COVID-19 patient. So here we welcome you all and we start beginning with our first session. I request Dr. Umanjali Madam to start with her session.
Yes, if you can share the slide, Madam.
I'll be sharing the slide. Umanjali Madam?
Yeah. If you can go on to the next slide, Madam. Before we start with the assessment, it is very necessary to know as to which patients are more going to require the rehabilitation after COVID. And looking at our own experiences, all of would agree that the most important thing that which the most important patients who require rehabilitation are the ones which have prolonged hospitalization. A prolonged hospitalization is like one of the most important components for rehabilitation. The patients who have been into high dependency unit, then of course the patients who had required high flow oxygenation are bound to require physiotherapy because their lungs are going to be involved to a great extent, and usually these are the people who have scores onto the HRCTs somewhere around between more than 10 and around 20. Then we have patients who are on who had been on ICUs or ventilators who require a lot of post COVID rehabilitation. And along with this, patients who have comorbidities also would be requiring rehabilitation after COVID. We can go on to the next slide, Madam. So a quick assessment charter for respiratory system. When we want to look at the respiratory system of the post-COVID patients, first and the most important thing which we see is the oxygen saturation at rest. And oxygen saturation at rest will tell us the idea, the status of the pulmonary system, how much rehabilitation protocols are we supposed to be giving to this patient. Then next is if the patient is maintaining his saturation at rest around 98, 99, that then we look after the oxygen saturation on normal activities of daily living. So we would ask him to perform 1 or 2 activities of daily living at the center where we are assessing this patient, and that would give us an idea as to how much oxygen saturation the patient is maintaining, and overall fast assessment of what is the status of his respiratory system. Next is if the patient is maintaining well saturation on his ADLs, then we would go on to the oxygen saturation levels on non-accustomed activities. Like for example, if a patient is a housewife, for her a non-accustomed activities is like just walking along a corridor, which she doesn't walk normally, she doesn't have to work so much. So non-accustomed activities for sedentary workers are going to be different. For people who are physically active are going to different. So this assessment is what we need to keep into mind. The next is a manual assessment of the respiratory motion. Manual assessment of the respiratory motion will also give us an idea about the musculoskeletal system, the musculoskeletal involvement or the musculoskeletal appearance of the patient, and how do we go ahead with the management. Can we go on to the next slide, Madam, please? Yeah. On to a quick general assessment when the patient comes to us, because we are managing, if we are managing, let us say about 10 to 15 patients of post-COVID, and we have to assess 10 to 15 patients into our OPD, then it is very necessary that we have a very quick general assessment as well. The posture of the patient sitting and standing will tell us about the psychological status of the patient and his overall involvement. Like a very good sitting posture will tell us about the confidence of the patient and his minimal involvement. A patient who is sitting with slouched and is stressed out will tell us about his respiratory involvement as well, because a patient who has oxygen saturation involvement, his posture is going to be stooped, and his accessory muscles are also going to be in action. So he's going to use his respiratory accessory muscles, and thereby a stooped posture is what is going to be obvious. So quick assessment of posture in sitting and standing is very important. Next is a gait assessment. This we can do as the patient is entering into the department or entering into the area where we are sitting for his assessment. A gait quick assessment will tell us about any gait deviations, that tells us about any neurological involvement, any musculoskeletal involvement, any tightnesses which he might have. A long-term hospital admission will also give him a lot of tightnesses, which we see when the patients we go on to the musculoskeletal assessment, which is going to be dealt with by, I suppose, Narsimhan sir. And we also need to assess any use of any assistive devices that will also tell us about his more neurological involvement. And overall gait assessment will tell us about his neuromuscular normalcy or involvement. A quick assessment of dynamic and static balance is also necessary. And what is important, I think so, is the patient reported outcome measure information system. Uh, Onto a quick assessment, we would ask the patient as to what is his normal daily activities and what is his assessment about his daily activities level. That is what I would put up onto the patient assessment measurement. Now, coming to the functional evaluations, these are very simple short tests which we can perform onto the patients, again, depending onto their oxygen saturation level. So a 30 seconds time set to stand test can be given to a patient who appears to be doing his normal ADL activities without any desaturation, who is maintaining his saturation around, let us say, 98 and above. The timed up and go test tells us about the mobility of the patient, the functional endurance of the patient. A 2-minute step test of exercise capacity we can give to a patient, again, who is maintaining a good saturation level about 98 to 99 at rest also, but who says that maybe I get exerted when I am doing accustomed activities. To such a patient, we can put up a 2-minute step test, but care must be taken that constant monitoring of the oxygen saturation is a must for all these patients. Then the other tests are 10-minute walk test, 10-meter walk test, 4-item dynamic gait index. A 4-item dynamic gait index is usually we would not do to every patient, but only a person who is complaining of any vertigo or who is complaining of any imbalances while walking. We would go in for a 4-item dynamic gait index. And of course, a 6-minute walk test for exercise capacity to a patient who is maintaining good oxygen saturation at rest on activities of daily living, and on accustomed activities, we would perform a 6 minutes walk test and try to find out if he has, how is his exercise capacity. Thank you.
I request Dr. Maria to start with her.
Yeah, I think I'm audible now. I was mute all this while. So, madam, I'll just let you know when to start.
Okay.
So can you just go back?
Yeah.
So I was just thanking Sancheti, the College of Physiotherapy and its staff for the Scientifica platform. And as we are moving into the second wave with an astonishing speed, we are surrounded by the cohort of post-COVID survivors who have faced the short-term and medium-term consequences. And we are left with both physiological and functional deficit in multiple systems that has come in. To highlight some concerns of the cardiorespiratory system, next slide, please, madam. With consent, I hereby present a case of a 50-year-old nurse who was diagnosed with COVID-19 while working in emergency setup in July. She was admitted with the complaints of breathlessness, was on NIV, HFNO, then weaned off to NRBM, transferred to the step-down unit. Her breathlessness was persistent, so post 15 days of admission, a CTPA was done and she was diagnosed as pulmonary thromboembolism. With the persistence of symptoms and very slow reversal, she was in hospital for almost 36 days and then she was discharged. 10 days later, she gets readmitted with chest pain, palpitation, breathlessness of grade 3 to grade 4. Her enzymes were elevated, IL-6 was elevated. So wondered whether it was a repeat. Again, she was COVID infection, but her RT-PCR was negative for the same. She was treated with stepping up of steroid doses. She was managed on oxygen therapy with low molecular weight heparin, antibiotics. Antifibrotics were added at this point of time, and she has been on continuous physiotherapy from the day one of admission of the first episode itself. She was discharged on home oxygen therapy after a stay of 50 days. Next slide, please, madam. If you look at her overall investigations and her changing CT pictures and everything, you find that she was diagnosed as pulmonary thromboembolism. She had ARDS. Her CT showed a gradual change from a bilateral ground glass opacities to going on to developing pulmonary hypertension and diffusing involving both lung parenchyma with fibrosis. Her echo showed from an insignificant pH moving to mild pH and from grade 1 diastolic dysfunction to grade 2 diastolic dysfunction. Even at this point of time in March, when her D-dimers were done and her enzyme levels were done, they were on the raised side, which was concern showing that there is an ongoing continuous inflammation and probably she still has a lot of coagulopathy. Her PFTs done in March indicated moderate restriction of the lung parenchyma. So what we saw is an overall picture where not just the lung, but the heart and overall musculoskeletal systems were also involved. She was on therapy for a long period of time and an intense therapy which began very slowly with low intensity interval training and progressed towards now at this point of time where when we began she was able to walk only 54.5 meters at discharge to at present to 436 meters with no pauses. She showed an improvement in her breathing capacity in the form of her breath holding time improving, her balance in the form of one leg stance improving, her hand grip didn't show much change and we were not able to test it again. Her 1 minute sit to stand test, which initially showed 5 and she desaturated and she had an RPE of 5 during all these activities, came down to RPE of 2 and she is able to do 22 counts. From ambulatory oxygen therapy and severe resting tachycardia and desaturation on activity, we moved over to night oxygen therapy and now she is off O2 with resumption of duty, carrying out all day-to-day activities, no desaturation, but a still mild hypertensive response and a resting tachycardia, which initially used to be like 108 and used to get pep up to 140 on just walking a few steps, is now in the range of 94, 95 at rest and going up to 100. This is now 8 months post-COVID, which tells us the long run, which tells us the long sequelae, and which also tells us that how multiple systems are involved with these patients and how we need to measure small doses, assess them at every point of time, monitor them intensively and move. Though she has reached 436 meters, it's a new baseline health that she has established over there. It is not same as it would be for a predicted normal. Can I have the next slide, ma'am? Razia madam, the next slide, please. So what is it that we have seen through as a post-COVID complication here? We all know that COVID causes COVID pneumonia, that is ARDS kind of a picture, which causes an inflammatory reaction, which builds in the cells, flooding it out, causing gas exchange to be affected. We have both a dead space effect and a shunt effect that occurs in over here. Next slide, please, ma'am. This patient of ours had a combination of the lung parenchyma getting involved, fibrosis is compliance getting involved, gas exchange getting involved, and multiple microthrombi. The coagulation profile of the patient changes because of inflammation. The virus attacks all the pathways of coagulation, whether it's intrinsic or extrinsic, causing a large clot as well as microthrombi which is caused by fibrin deposition, activated platelets, and neutrophils, which form nets into the small microvessels. And these in turn, next slide, madam, please. These in turn cause remodeling. They cause remodeling on the cardiac system. They cause a load because of increased pulmonary vascular resistance. They cause pulmonary hypertension, and they cause heart failure with preserved ejection fraction. And that is what we saw in her. We saw that she had diastolic dysfunction, pulmonary hypertension, and to a certain extent, she was beginning to develop right ventricular dilatation. Her enzyme levels still staying high was a cause of concern, and that is why a repeat CT, repeat reports, and everything were taken. She has been on medications to take care of the coagulopathy, and that also occurs as a cause of concern for us while we are treating her throughout because of the possibility of small vessels continuously getting involved. The supplemental oxygen helped her where the ventilation perfusion mismatches were there, where the dead space was more, and physiotherapy contributed in improving and minimizing ventilation perfusion mismatches, reducing the triggers that would increase the breathlessness, that was the pain and emotional stimuli, the peripheral chemoreceptors, and the juxtareceptors of the mechanics of the breathing, the vagal irritants. So all this was taken care through the breathing exercise protocol and a gradual graded exercise protocol that was given to this particular patient. The next slide, madam. So in brief, what I'm trying to convey is the patients were present with a varied kind of symptoms and symptomatology. The sequelae can last for months together. A holistic approach and a holistic assessment needs to be done in this patient, and an individualized tailored pathways need to be formed. You may have combination of a neurophysiotherapy, you may have a combination of a respiratory, and those with pulmonary hypertension, you may have cardiac involvement, and later on a sequelae of a myocarditis may develop. So they need an intense monitoring. You need to be into the team to keep on referring back at the points where we feel, as she suddenly presented in between 2 weeks back of chest pain and all, and that's the point of reference where we sent her back and they repeated the D-dimer and the enzymes and everything. Most of these patients have shown evidence of abnormalities on the scans. 35% have shown almost fibrotic-like features with a persistent into ILD. And as a physiotherapist, I think we play a huge role in helping them to combat the sequelae and come back to the normalcy and resumption of life. Thank you. That's all I want to convey.
I request Dr. Anjali to unmute herself.
Yes. Good morning, one and all. I would like to thank Team Scientifica for giving me this opportunity. Like Madam rightly said, we are facing the aftershocks of the pandemic. Madam has already covered the chest portion. I wish to cover the musculoskeletal system now. Next slide, please, Madam. A number of clinical syndromes are emerging as post-COVID sequelae. The post-intensive care syndrome, PICS. Next slide, please, madam. Critical illness can have a major impact on areas of participation. The impairments in physical, cognition, and or mental health resulting from critical illness are described as post-intensive cardiac care syndrome or PICS. Studies have shown that even after 1 year after ICU discharge, 56% of patients suffer from one or more problems. Studies have shown COVID patients with ICU stay are presenting with critical illness, myoneuropathy, cardiometabolic dysfunction, sarcopenia, and cognitive impairments, which result in impaired functional capacity, thus hampering their ADL activities like grooming, bathing, walking. Thus, quality of life is markedly reduced. Studies have shown that 30 to 80% patients have problems remembering, paying attention, solving problems, and cognition. They have also problems with sleep, falling asleep, and staying asleep. They may be anxious and depressed and may also have nightmares and unwanted memories about their stay in the ICU, not just in the ICU, even out of the ICU, thus showing symptoms of post-traumatic stress disorders. Next slide, please. Okay, madam, the same slide, previous slide. Post-viral fatigue syndrome is another syndrome we are facing. Although COVID-19 is relatively mild in most patients, many patients report fatigue as the most common long-term issue. It is most persistent and debilitating. Fatigue is defined as the decrease in physical and or mental performance that results from changes in central, psychological, and or peripheral factors. Studies have shown that 50 to 75% patients report fatigue. It is more in females than in males. More fatigue is seen in patients with higher BMI and previous depression. There seems to be no association seen between acute symptom severity and the prevalence of persistent fatigue. Changes in neurotransmitter levels, that is serotonin and dopamine levels, inflammatory cytokines, excessive release of cytokines, psychological disorders, stress levels, cognitive function contribute to fatigue. Post-viral fatigue is usually self-limiting, and but risk of chronicity is strongly associated with several factors: biological, social, behavioral, cognitive, and emotional. ME and CFS, myalgic and encephalomyelitis or chronic fatigue syndrome. It is a common it is a syndrome which we may see or we are already seeing in patients. Fatigue which lasts for more than 6 months duration can be labeled as CFS. It is the chronic variant of fatigue where exercise intolerance is the key feature. Physical or cognitive exertion leads to debilitating fatigue not relieved by rest or sleep. Post-exertional malaise is the most common feature. Next slide, please. Next slide, please, madam. Myalgias and arthralgias and generalized weakness are also present in these patients. Studies have shown that 1/4 to 1/2 symptomatic patients with COVID-19 present with myalgias and generalized weakness. Systemic inflammation induced as a result of COVID-19 viral infection impacts the musculoskeletal system, leading to myalgias, atrophy, weakness, and fatigue in the skeletal muscles, and arthralgias, bone mineral loss, osteonecrosis, and chondrolysis in the bones and joints. Cytokines and pro-inflammatory molecules like CRP and interleukin 6, which increase manifold in COVID, leads to pathological changes in the skeletal muscle tissues like muscle fiber protein lysis and decrease in protein synthesis. They also block the satellite cells, the progenitor cells responsible for muscle growth. Extensive use of corticosteroids also induces muscle atrophy and weakness. Systemic inflammation also has its effect on the bones and joints. Interferon gamma induced protein 10, interleukin 17 and TNF alpha induces osteoclastogenesis and decreases osteoblast proliferation and differentiation, leading to decrease in bone mineral density and chondrolysis, which results in arthralgias and progression of osteoarthritis. Studies have also shown and reported many patients with COVID are presenting with symptoms of GBS 3 to 4 weeks post-COVID. There are few incidences of facial palsies also, and peripheral nerve involvement is also seen in some patients. We have seen patients with foot drop also. Hypercoagulation has also been noted and has resulted in strokes. Headaches are also very common following this infection. It is assumed that activation of cytokines, especially increased TNF alpha and increased prostaglandin E2 levels in the CNF, sensitize and stimulate trigeminal ganglia, which results in overproduction of calcitonin gene-related peptide, which plays a crucial role in the pathogenesis of migraine. So we have seen that this musculoskeletal system is equally involved, is largely involved, and fatigue is a mechanism which is very, very common, not just in the patients who have stayed in the ICUs, but even in patients who have been staying at home, having home quarantine. Thank you.